Good morning, good afternoon, wherever it is where you are. I am Dr. Twine Daniel, and I'm so glad to participate in this COESCA conference. And I want to appreciate the host. Thank you for inviting me. And I'll be talking to you really about the role of routine data in epidemiology. But just before that, let me share my presentation with you so that you're able to follow along. And so I'll be talking about the role of routine data in epidemiology. And just for the purpose of introduction, I am the director and the founder of SOA Research Foundation. I'm an epidemiologist, and I've been working for MSF Epicenter in the research department for over the last 14 years. And I'm a visiting lecturer in Mbarara University of Science and Technology. So I'll be talking about a number of things today, and one, I'll be talking about the relevance of this topic really in the context of COVID-19 pandemic where we are now, and also to give you a small brief about SOA Research Foundation, just to complete my introduction and what we do. And I'll talk about a brief about epidemiology, and again, be able to contextualize the position of routine data by talking about primary and secondary research. So I want to start with the importance of routine data, and as I talk about that, I want to appreciate really the host for choosing this topic, because in the pandemic time, what we have observed is that there has been a difficulty in people doing research and collecting primary data amidst restricted movements and closure of universities and health facilities being downscaled. And the need for routine data has come to the front, especially for the academics and the students who are doing postgraduate. And it's important really to understand how helpful it is and how we can leverage on it to be able to advance research. And so it's a really very important session that I'm happy to be a part of. And just talk about SOA Research Foundation. This is where really I come from, and we are a registered private research-oriented organization, and our focus has been on a number of implementing services that have to do with research. We started as a grassroots research consultation organization in 2010, and we have evolved to a point of implementing researches and taking on contracted research on a wide scale. We support students and postgraduates, PhDs in carrying out their research, and our motive is to ensure that there is good quality research that is produced on all fronts. So we are based in southwestern Uganda in Mbarara city, which is far away from the capital, and this is a place with a growing momentum of research given the increasing number of universities and many people engaging in research. Unfortunately, there is limited expertise on different aspects of research, so where SRF really stands firm to give this support. We engage in a lot of data curation processes, data analysis, supporting on protocol development, conducting systematic review, implementing researches ourselves, but also in collaboration with some of our collaborators. And we take on contracted research, and we are always open to work with many people. So looking at even an experience we had, again, in the previous years, according to the graph you can see here, we have seen a lot of increase in consultations that we have had as an organization. But what I want to bring to your attention is the effect of COVID-19, like the pandemic in the 2020, when universities are closed, research momentum was down, and many students, many researchers could not collect data, primary data, because of this restriction. And this is why you see that, research should not have such a dent if people can use routine data. And that's a very important thing for us to emphasize. Now, to start with epidemiology is an amazing discipline, and the word epidemiology comes from the Greek words epi, which means on or upon, and demos, meaning people, and logos, meaning the study of. So it's a study about people. So epidemiology doesn't have to do with animals or plants. It's people. And in epidemiology, we view, things in two fundamental directions or assumptions when we are dealing with disease and health conditions. Is that human disease does not occur at random, but there is a form of variation in distribution of disease and disease conditions and patterns in which it's distributed in a population with regard to the personal characteristics, time which can be in line with duration or seasonality, and then it can be according to place where people stay, what they're exposed to. So disease can vary in those lines, but also we appreciate that the human disease or health conditions can have causal and preventive factors, which we can leverage when we want to stop progress of a disease in a population. So by understanding those causes and those preventive factors. So when you're doing research, those are things we are thinking about. So the definition of epidemiology is the study of distribution and determinants of health-related states or events in specified human populations, but also the application of this study to the control of health problems. So when we are doing an epidemiological study, we are thinking about also how it will be applied and how it will help the public health administrators to be able to control such problems. What I want to pick and bring to your attention, which actually make a foundation of the research we do, and in this regard also routine data use, is the components within this definition of epidemiology. One is distribution of disease. This has to do with the frequency, quantifying how common a condition is and how it is distributed through the specified population. And this is very important in formulating hypotheses, and which we may take on to find out on the causality and preventive factors. Two, determinants of disease. In epidemiology, we look at how can we find the causative or the risk factors for someone getting a particular condition. And this helps us to know who is vulnerable and who needs to be supported to ensure that they live a good life and a healthy life, and then we're able also to know how to stop disease. Then health-related states or events is another component we have in the definition of epidemiology. So we don't talk about just disease, but over time the definition of epidemiology has progressed from just disease, but to also include things like behaviors of people and lifestyles and chronic diseases and a lot of other things, using of seat belts, using of glasses, and all that is health related, and it can be considered in epidemiology as something to study. And then specified human populations. So epidemiology has to do with whom are you studying. At times we study patients who have the disease already, others those who are at risk because of their exposition, but also at times we do research among the healthy population. And another part of the definition of epidemiology is the application. We think about what I'm doing, where will it be applicable. When you're doing a proposal, you always think about the justification of your topic. So we talk about where will the application be. You don't want to do a research and which is going to be useless, which is not going to be used. We think about the application of the findings that we have. This I've mentioned just to I was trying to break down for you the health-related states and what is involved within the health-related states. and how the definition of epidemiology has actually evolved to involve much more things than what it was before. So whenever you think about doing a health research, I want you to remember that there are a number of things that drive us and to do a health research. And this is where we get the question, a research question. And when we do health research to measure and analyze at time health and illness, at time we want to know how many people are healthy, how many people are sick. At time we are studying directly the nature of the disease, how it presents, how the complications of that disease. At time we are doing research to measure the need for care. At time we want to know how many people are vulnerable, how many people are sick, and how many people need a certain kind of care so that it guides our implementation of care. At time we do research to find associated factors with the use of a certain service. You implement a service in the eye clinic and you want to evaluate it over time to see how many people are accessing it and which group of people is there a certain class that cannot access, and maybe that can drive you to make a few changes on how to make that service available. And at time we do research to assess the effects of care. You know, you have implemented a drug, you have implemented a new technique, you want to see the outcomes of that technique. At time is the acceptability of care. Time we design and spend time in designing a good service, but it's important to really evaluate and say, okay, well, how are people accepting it? Are they adopting it? Are they loving it? Because one of the important roles of health service is the satisfaction of the patients, the satisfaction of the participants. So all the things can drive a research. And organization of care, time, you know, we need to organize care so that it's safe. Now we're in a COVID season. You don't want to organize the movement of patients in the health facility in such a way that they can transmit infection from one point to another. So at time we are studying about the organization so as to shorten the time a person spends in the system, or you want to understand how you can prevent nosocomial infection by organizing people to move in a better way. Then at time we do research to assess the efficiency and effectiveness of a medical intervention. You introduce an intervention like, some of the interventions you have in eye care, and you want to assess whether it has been effective in giving good results, over time. So time we do research to assess the quality of care. The quality of care is very important. And whether you're doing private care or practice, or you're doing public practice, all of them are interested in improving care. And that's really very important. Then understanding causes and consequences of health inequalities and also health behaviors. So those are areas that you can do research in. Now, when you think about a research question, you want to find out which data you want to use. And it can be primary data or secondary data, and we shall see the differences. So that's why we talk about the variety of sources of data. And the choice of which data source, has to do with you evaluating the skill sets, the skills you have to be able to collect that partial data. At times you don't have the skills, at times you don't have the resources like equipment to collect that data. So it may be better to use secondary data where people have already collected it using that equipment. And at times the funding, how much money do you have? The budget constraints can also drive you to make a choice. And also time constraints. How much time do you have to collect the data? So just in a bigger context, what are the differences between the primary and secondary research? So the primary research involves collecting factual or first-hand data at the time of the research project. This is where you make your questionnaire and then you go and ask people to participate in your study and collect data real time. That is primary research. Secondary research, on the other hand, it involves the use of data that was collected already by someone else or technologically auto-generated in the past. I mean, machines can produce data that you can analyze. And that data can be existing for other reasons other than the study that you're doing. So secondary research also uses past data, while primary uses real-time data. And in terms of the person who collects data, the secondary data was collected by someone else other than you. While in primary research, it is you who collects your data. And the needs. Secondary data may not directly address the needs of the researcher. At times you have a question, but the data you have may not really answer your real need. But maybe it can contribute to your understanding of what you want to investigate. But primary data, you have a freedom because you can go out and correct and ask the real questions that you want answered and collect the data that you really need. In terms of involvement in secondary research, the researcher is less involved. At times, well, if the study was done in your own organization, you may have had a bit of some interaction with it. But in the normal sense, in secondary research, the researcher has no previous exposure to that. And then completion time when you use routine data or when you do secondary research, it's a bit shorter and the cost is always low. So advantages and disadvantages of secondary research, or you could call it routine data. One, the first advantage is that it's not expensive. It's easy to collect this data because it's there and you can do this research. Faster, it saves time. It's easily accessible. This data can be easily accessible. You just get permissions from the hospital directors and be able to access it, or from the owners of the data. And you can have a large scope of data in one piece. You know, imagine data collected from patients for 5 years. It's too many patients in some high output clinics. So you have a privilege of big data, of large amounts of data. And if it is professionally collected by people that you are sure are skilled, then it's giving you a bit of more confidence of its quality. And you can use it to actually see the trend of certain disease conditions or practices over a long period of time, which could be very difficult for primary data. And it can also be used for exploratory phase when a condition is new and you want to first assess on what you can learn from the existing data to give you an evidence base to be able to progress to maybe a primary research. So it can be used that way, and it's really very helpful. So some of the disadvantages with routine data or use of this data is at times it may be inappropriate for your research question, and that is at times a setback, and so maybe you may want to choose to do a primary research in that case. Or at times it is corrected in a wrong format than what you require, or at times it may not answer the research question that you actually have, or at times there is lack of control over the quality of the data because you are not part of the data collection at first. So the control, those who documented that data, some may leave out certain things and cause you to have an underestimate, okay, of what you are assessing. And some may exaggerate because of misdiagnosis of things. They had no good capacity to diagnose properly and can give you an exaggerated picture. At times there's lack of sufficient information completely, really, and missing data is one of the biggest challenges here. And also when we see the available secondary data may be outdated. So it may be so many years and things have changed so quickly and you cannot use it. So what methods do we use when we're doing secondary research? One, at times we can use secondary data in isolation, meaning you use data from a certain clinic alone or in a certain hospital alone without adding in another hospital or a different setting, or you're using a data set of someone who collected data before and in one setting and you just use that. At times, we combine two secondary data sets. For example, when we want to compare really findings in different contexts, one facility may be using a new intervention technique or a new technique on treating cataract, while another is using a different technique, and maybe you want to compare the two and see which one works better in different contexts. So then you may have to merge two data sets. And then at times you may combine a secondary data with a primary data. And that means you're correcting fresh data and you want to compare with what it was before. And because you are not there before, you may use secondary data to tell you a bit how the prevalence was before and what it is now as you're correcting it afresh. So there are two main types of secondary data and their associated purposes. So data terms as it's being corrected, it might be corrected quantitatively in terms of numbers, in terms of statistics. Or at times, someone may have done a qualitative study before, which you can use, that qualitative study, you can use it to inform you on how to construct a quantitative study where you're going to collect primary data, you know. So if someone assessed patients on their level of satisfaction, perceptions, what causes them to delay to access care, you can pick from that and it can work as your evidence base to build another quantitative study, all right? Or another qualitative study, which might be primary. So meaning you can analyze this historical data or secondary data and it can inform you. The same thing with analyzing quantitative data if it was collected, and it can give you a bit of who is more affected, who attends the service and who doesn't. So if you can try to analyze it as it is, or it can inform you to create another primary research. And there are two sources of secondary data. Where do we get this data from? Where do we get this data from? It can be internal sources or external sources, and these both have their implications. Now, internal sources is you are collecting data from the organization you work in or in the same hospital you work in. So in a way, you have a bit of confidence on the systems, you understand how it's collected, and there may be less, things to really worry about. Unlike when you're dealing with external sources, at times you have to use external sources like getting data from government sources, national or international institutions, scientific journals when you're doing systematic review and meta-analysis. You're using journals, and then private research organizations, which is not your primary place where you're affiliated. So in a way, depending on this, you may need to employ more methods of how to assess quality and to ensure you get used to how things run in the external source. So administrative data, for example, what is involved in administrative data when you come to a health facility, maybe a hospital, and you want to use routine data? Some of the routine data may have to do with the diagnosis, because every patient who comes, they have a diagnosis. Demographic data is collected from them. At times there's data on drug prescriptions and the intervention they have received, the kind of care they have received, and also the bill information, how much money they are paying. Someone may want to do a cost-effective analysis study just to see how much it costs for someone with cataract from time they get the symptoms to the time when they are fully operated and recovered. So they will want to use a bit of those billing information. So all that is routine data, but which can be very informative in the planning of health services. Now, each patient's contact normally is captured as a unique variable within the facilities. Each patient who comes, they have a unique number that is given, and all that helps you to be able to track and link information that you collect in that place. The secondary research process, it follows 4 processes. One is development of your research question. If you're going to collect routine data and you're going to do secondary research, develop a research question. That's the first thing to do. Number 2 to think about is identify a secondary data set. Find out where you can get a secondary data set, or are you going to collect data from the patient files? At times someone has done research which is broad. Maybe they explored the common eye conditions in that setting, and you may want to just for you pick on the cataract and study about cataract. So you can use that data set and do a sub-analysis. So you're using secondary data even in that instance. And The third thing is that you have to, if you have a data set or data, patient files or whatever source it may be, you want to evaluate it. You want to evaluate it to see if it's of good quality, but also if it can answer your questions. Now, in this evaluation, what do you look at? You look at what was the aim. What was the aim of data collection? What was the aim of the data which was collected? Was it collected for routine care, or it was collected for research or for evaluation? So depending on the type of data, it will tell you how much you have to do with it in terms of quality. And what was the aim of the original study? You want to know that. And who has collected the data? Is he a professional? Can you trust their accuracy? All this is very important. And which measures were employed? What did they use? Was it collected using well-structured interview guides, questionnaires? So if it is well-structured, that's much better than someone writing in a book, in an exercise book, a patient history. So structured tools help to give you a bit of a systematic way of collecting data, even in routine context. But when someone is just writing, every doctor is writing their own way, then there is a chance that some important variables will not be found. And when was the data collected? You must know that. Some data may have been collected long ago and it might be outdated. So you may not be interested in using it. And then what methodology was used? You want to know whether the sample, the number that is there, is representative of the population. Is it sufficient for you to do your secondary research? And was the analysis, if you're relying on papers which have been published and you're doing systematic review, you want to assess them also on the methods they use and also the analysis that was done. Was it a good and appropriate analysis? If it's qualitative research, did they use thematic analysis? You want to be sure. And then finally make your final evaluation about the data that you have at hand. And then you can be able to make use of it. Then prepare and analyze the secondary data. And with that, I could not go ahead a bit of the analysis maybe for another section, but that's what you need to know about, at least as a background to routine data in epidemiology. And that slide has a bit of my contacts and our contacts just in case you want to contact us for any service. Otherwise, enjoy the conference. Thank you.